soon as I get the go-ahead from Gordon that we're recording, because so you guys know this was planned, but also, it's our first time, so the details and the logistics and all that sort of thing has been.
Good to go. If you want to stand a little closer to that microphone area, we're picking you up.
Sure.
You see up on camera.
I don't want to be very close to him. I'm just.
We are good to go.
And we're recording, Gordon?
We are recording.
Awesome. So welcome, everybody. Thank you all for coming on a Saturday. I hope we get to do this approximately every 6 months or so with Bassem, and we've got other faculty that were otherwise committed this weekend, but they'll be joining us in the future. We'll continue with the monthly evening journal clubs. We talked to Dr. Ayanati, who's one of our mentors, like a guy who we look up to, and we're hopefully going to have him for the month of October to talk about pre-op planning for shoulder replacements. So we got a lot of exciting things for today. I kind of built in this half an hour buffer. I was like, half an hour for introductions. Like, introductions take like 3 minutes. Like, getting everybody in and settled and changed, that takes half an hour. So we're right on time. We got plenty of time today to talk about two really broad topics that we're going to try to make as specific as we can, just so we're not kind of all over the place. There's lots of things that you can talk about with scapular mechanics, and Dr. Elhassan is going to focus today on the functional anatomy of the scapula. And then after he's done his lecture, we'll go to the lab and we'll do the anatomy in the lab, focusing on the functional anatomy for the scapula. We'll have lunch, and then this afternoon I'll be giving a talk on rotator cuff biomechanics. Hopefully we'll have our buddies from Jefferson and Cleveland Clinic zooming in that are, I would say, thought leaders in the field, and up-and-coming thought leaders in the very least. And they'll be joining us via Zoom this afternoon to talk about rotator cuff biomechanics and some specific things that we learn about the rotator cuff through rotator cuff pathology. And then we'll go back to the lab. So we'll do the big picture with the scapula, and then the sort of more zoomed in with the rotator cuff. All of this is going to be interactive. Like, this is, like we've always done it, like very family open, like, hey, like, this is what I think, could you consider that? And, we'll discuss it. And you guys know how much I learn at these things from you guys. And it's awesome to have Dr. Elhassan here, so we can add another layer of education for all of us. So I'm looking forward to it.
Thank
You
you.
ready, boss?
Oh yeah.
All
Thank
right. He doesn't need an introduction, right? You guys know the co-chief of the Harvard Shoulder
Recording in
Service,
progress.
Mass General, world famous scapulothoracic expert, so on and so forth.
Thank you.
All yours, boss.
Thank you. Good morning. Thank you for being here. It's a great facility, by the way. I'm very impressed. I'm very glad I came here. This section reminds me very much of the Mayo Clinic. This is how it is exactly done in the lab. I think most of you were present during the prior scapulothoracic. So this is going to be reinforcement, and I'm going to pick on more things. Right now, you can ask me like any questions, because there are a lot of things about the philosophy of the scapulothoracic articulation that we're still learning. I really think the therapists know the best. Not because you are here, guys, but I think they know the best. It's very amazing to me how many times they can pick on diagnosis before certain surgeons be able to pick on them. But there are still a lot of things we have to learn, because what I tell not the therapist but the resident fellows is, for years and years and years in our education, the scapular pathology is essentially the term winging, dyskinesia. If it's winging, it means either serratus or trapezius paralysis. Dyskinesia, you have some shoulder pathology, and some scapulothoracic bursitis. So that's it, nothing else. Which, in my opinion, is not correct, because there's so much more than this. But this is how we learned all the time, and we followed it all the time. But then we start to realize there are much more than this, and this is what we're going to talk about or try to understand today, and we're going to keep on understanding. I'm going to start first. This is was it on America? I think this is America Got Talent. So he's an EDS, Ehlers-Danlos syndrome. And these people, they always get like a golden buzzer because they're so flexible, they can do stuff. But so this guy, he can, yeah. Yeah, he's an EDS, Ehlers-Danlos syndrome. They can do amazing thing. And we have a lot of patients with EDS. They come ask me, like, my shoulder subluxate, have pain. I tell them, like, the million-dollar question, why some of you can go to Cirque du Soleil or be on these shows, and they can do amazing thing, and others, they come and they're miserable, their shoulder not working. I don't understand. This is a million-dollar question. But the big question, what is the borderline between, well, hello. Okay, between what is normal and what's abnormal. Like why this patient, the first guy, he's not a patient, and he's showing his scapula moving almost like what you call it, a tiger. And this patient is very abnormal motion, but at the same time is very dysfunctional. So I always quote like Albert Einstein, we have to understand what's going on, otherwise like we cannot address it. If you cannot explain it simply, you don't understand it well enough. So I would say the shoulder is very elegant, complex, and sexy joint because there's no other articulation or joint in the body like this at all. Because you can do amazing thing with it, and it is different than the hip, is different than the knee, is different than the ankle, is completely different for many reasons. This is one of the main reasons because when we say shoulder, it's not the glenohumeral joint. Shoulder is shoulder, the section here that move the arm. When we say shoulder in general, we think it's only glenohumeral joint, which is not correct because the shoulder is made of 3 joints and 1 articulation. If there's a pathology in any of these, there's dysfunction of the arm. So this is very important when we talk about pathologies and why some people have a perfect deltoid and rotator cuff, still they cannot move their arm if they have an abnormality of the scapula. For whatever reason, we separate the scapula from the shoulder. We say glenohumeral and scapula. They're the same exact thing. It's the same bone. And this I always presented. I keep on always presenting it to remind people about, and those who are interested, that there are 14 muscles that move and stabilize the shoulder. 8 that specifically work on the section of the glenohumeral, and 6 on the scapulothoracic. But essentially all of them, they're one entity. So the scapulothoracic articulation, there are, like the 6 we're talking about, are the serratus anterior and trapezius. These are the 2 massive muscles that specifically stabilize the scapula movement on the chest. And you have a smaller muscle that we don't ever see and think about except when they start to cause problem. Levator scapulae rhomboid minor, rhomboid major, which is deep to the trapezius, and the pectoralis minor, which is a very annoying muscle. And this is, I went back, like this is how we try to study the shoulder, because in essentially almost all studies about the mechanics of the shoulder, they use the scapula, they glue the scapula on a board and they show the shoulder moving in different direction. But in reality, as you know, like you have to have the hemitorso as almost a full hemitorso to be able to appreciate the mechanics. And this is how we work on be able to understand the mechanics around the shoulder. The very, very simple way is the following. The scapula is the house of the rotator cuff. The rotator cuff stabilizes the humerus on the glenoid, humeral head on the glenoid, for the deltoid to be able to work, together with a stable scapulothoracic articulation to be able to have a good function. So this is a very simple summary of this, that you need a stable humerus on the glenoid, deltoid to be able to work, and along with the scapulothoracic articulation. And so this is why, like, again, I try my best to always, when tissue resonance fellows, tell them, please don't separate them. And I always make them examine the scapula no matter what the patient coming, even they're coming for biceps tendinitis, so that they get the gain of the understanding. Because even from this looks like nice animation, and it's distracting because it looks nice, but in reality, if you look at it, we focus here only. But in reality, the shoulder is this whole area. So if you want to move your arm, you need to have every single structure is good. If someone has no clavicle, the scapula is going to be down. You can have a disturbance. If you have SC joint pain, you cannot move it very well. If the scapula is unstable, you cannot move the shoulder very well. So this is very important. And then, so this is also reinforced the importance of the two massive muscles in the shoulder. By the way, the serratus, there is no direct exam for the serratus. And we're gonna show you more like what we do indirectly. Why? Because it's hidden. It's deep to the scapula, it's hidden. And today, hopefully, I'll be able to show it. So the serratus is hidden deep to the scapula. So when you examine it, it's indirect exam. People do the push-up, like they taught us over the years push-up test, and I have a new study right now to show this push-up test is wrong, by the way, because it mimics other pathologies. But indirectly, if you do push-up and the scapula wing off the chest, this is an abnormal serratus, but there are other pathologies can cause it. The trapezius is more direct exam because you can see it. You can feel it, especially if someone is not fluffy, if skinny. If skinny, you can touch them, you can be able to see if they're fluffy 3 or 4, it's very hard to feel trapezius. So, and this is where it becomes more tricky, but they have very different function. So the serratus try to keep the scapula on the chest wall and try to during motion to protract it on the anterior chest wall. And the trapezius, and we spoke about it last time, is the only muscle that originates from the base of the neck to the shoulder to hold it up. Without it, the shoulder is going to drop down. So they have two different functions, but they're very important. Now, to appreciate the function more, again, because we don't focus about this one, if someone is an athlete and they try to stand on their hand, this is not a pure deltoid and rotator cuff function. You need to have an excellent, stable scapulothoracic articulation for them to be able to do this. So this is from Ledja and Eidsmuller. This is not mine, but they have this this is essentially thousands of pictures, not a video, so that they can capture this motion. This athlete, I think he won several times the Olympics. But notice, like specifically here, in this position, imagine the scapula is not stable. Imagine the serratus not pulling forward and the trapezius is holding. What's going to happen? The whole mass is going to fall toward the spine, and they're going to fall. You cannot support yourself if the scapula is not stable. And this is really, you can see, look at the trapezius, how he's firing beautifully the trapezius here. Even though the deltoid is working, but he's essentially really using every single periscapular muscle. The trapezius, you can see here. So this is very important. And you can see this from this view, it's perfect. Because again, imagine now this is not stable. If the serratus is not able to hold the scapula down and pull it forward, what's going to happen? This is going to go toward the spine. It's going to fall. There is no structure. There is no support. And this is just, again, to reinforce the importance of these muscles. And we spoke this one about, and this is, I feel it's a very simple but very nice way to understand how the scapula, if there's abnormality in the scapula, which is the shoulder, then the function will be disturbed. So the scapula is the house of the rotator cuff and the house of most of the deltoid. Like most of the deltoid is on the scapula as well, but part of it is on the clavicle. And it is sitting on the posterior chest. This is important in terms of orientation, anatomy, and later if we try to do any kind of reconstruction. So if this house is disturbed, whatever is in it will be as well. So this is a very simple way to show you, like if you have a house which is kind of like bent or twisted, you have to try to balance yourself to stay in it. And this is what happened to the rotator cuff when they try to function. And this is what happened to the humerus. Sometimes they dislocate. So I have a number of patients who had 2 or 3 capsulolabral shift and surgery, and the scapula was abnormal. And they keep on having recurrence because the scapula was abnormal. If the scapula is abnormal, it's very easy for the shoulder to subluxate posterior. And if you miss it, no matter what you do inside the glenohumeral joint, they're going to keep on dislocating because the basic structure of the house is unstable. So we had to do a stabilization for the scapula, and the patient did very well. If the scapula is not stable, this is what will happen. The shoulder will be dysfunctional. Look at this. This is what I told you about the athlete who's trying to stay on their arm. If the serratus is not stabilizing the scapula and pulling it or protracting it, it almost touches the spine and it falls over. And that's it. You cannot anymore having the support and the stability, and the shoulder function will be disturbed. So this patient has a perfect deltoid, has a perfect rotator cuff, but she has abnormality both of the trapezius and the serratus. And you can see how the scapula is falling down and she cannot move her arm. And this is just to reinforce the importance of the concept that the scapula is the essence. The glenoid is a small part of the scapula, and the shoulder is the rest of it. So it's really, really very important. And this is really why I dedicated essentially all my work career into understanding it, because it has been missed a lot. And this is also, we spoke about it last time. I did slightly, not change, but came up with a different terminology, mainly just to decrease the confusion. Because for years, when someone called me, I'm sending you a patient with scapula winging. In their mind, winging, because they have either trapezius paralysis or serratus paralysis, they need some tendon transfer. Or if they say dyskinesia, it means just some abnormality. They use it almost like a diagnostic, while it is descriptive. So we came up with the term STAM, scapulothoracic abnormal motion. This encases everything. So if someone has a STAM, just try to examine and figure out the reason of the STAM. Stop saying the winging or dyskinesia. You want to say them as description? Yes, like this patient, you're examined, there's a winging. Okay, this is the description of the pathology, but it's not diagnostic. And I thought this time, because again, last time I spoke about this, we're gonna go about the reason of the STAM, like when the STAM does happen. And we have a number of reasons that can lead to scapulothoracic abnormal motion. From the simple, we're gonna go from the simple to the complex. So, and again, this is in case or entail everything around the scapulothoracic articulation. So far is okay? Any questions? Okay. So we'll start with the simple. The scapula is like laying on the chest, and I showed in the prior presentation that if you take this, if you cut the muscles from around the scapula and dissociate the AC joint, the scapula is gonna fall off. There's nothing to support it. And you have a bursa between the scapula and the chest wall. So if you have an abnormality of the scapulothoracic bursa, this can cause STAM, abnormality of the scapulothoracic motion. This is one of the simpler ones. Now, you have a number of muscles that I showed you attached to the medial scapula, like levator scapulae, rhomboid minor, rhomboid major. And this is, I have to give credit to Ben Kibler about this one, because if you have detachment or injury to some of these muscles, this can lead to STAM, can lead to pain, can affect the shoulder function. And for me, the diagnosis for this is almost always only physical examination, because they have pain very specific, very localized, the tenderness. And in my opinion, MRI does not work, because MRI, most of the time, they come with a negative MRI. And part of the reason, because I think, I'm not a radiologist, but part of the reason when you do MRI for the shoulder and you go sections, the rotator cuff almost like a tubular with a tendon. So you can get cuts to get exactly what you need. These muscles are flat, very flat muscles. So to get the cut correct, to get where the tear is, will be very, very unlikely or difficult. But this can cause, as I said, they could be generator of pain and cause STAM. And the next one will be what we talked about it last time, is pectoralis minor hyperactivity. In pectoralis minor hyperactivity, what happened is they behave exactly like quote unquote serratus paralysis, or because this is, I don't like the term medial winging and lateral winging because it's very confusing, but it causes the distal tip of the scapula to wing off the chest. But early on, when I started my work, and based on everything I learned from fellowship and before, I used to say, oh, that's a big time winging, definitely her serratus is not working. And we realized we were wrong. It's not it, because there's a number of muscles around the scapula that can cause exactly this kind of deformity. And you can see how the scapula is winging big time. Now, this patient is subluxating posteriorly at the same time. So whenever she raises her shoulder, the scapula go out and she dislocates posteriorly. And the problem is pectoralis minor hyperactivity. So, and I'm gonna show you, and we showed it last time, but I'm gonna show you also how I rely on exam to figure it out. This patient, she sent me a picture of her and her cousin just showing off how they can wing her scapula off the chest. So nothing, this is not pathologic. And she was, this another patient sent to me to show me, look, her scapulae are very abnormal. She's doing the whole push-up test. And then when she came, I realized this is not correct. She has normal scapulothoracic mechanics, but abnormal activation of the muscles around the scapula. So, but this is because this is from her house, but I will show you what I did in another patient. This motion specifically show you that the serratus work. When you go all the way and you push on the wall, if the scapula doesn't wing off the chest wall, it means the serratus is working. But I will show you this. This patient, you can see, he does have the scapula wing of the chest. You want to call it medial, lateral, whatever you want. I don't like the terminology. So, and then he's doing the push-up. This is positive. So if anyone like trying to understand and think like this is probably serratus paralysis, because this is what they taught us, like do the push-up test. And if it's positive, it's abnormal. So you can see it again. Now, the scapular stabilization test is to mimic the serratus function, and the patient gets better. Again, this is almost like more confirming that this is like probably a serratus paralysis. However, this is again not correct. So we came up with what we call it the shoulder flexion resistance test. And this is, I'm glad Mina now he's using it often. So we do the elbow extended, okay, and the shoulder flexion at 30, 60, and 100. And no matter how much patient has winging of the scapula of the chest, if the serratus is normal, and if you can get beyond the 100 and push, and the scapula will sit on the chest, it means the serratus is normal. So you can see this is not my patient. In fact, this is a colleague of mine. He works in Hawaii, in fact, and this is a patient of his. But he was doing the test. He did it. I think this is his. This is flexion against resistance. Look, when he get up to 100, he go to 30, it's slight winging. Go to 100. And push against resistance. The only muscle supporting the scapula here is the serratus. So if the scapula is stable on the chest, the serratus is normal. So now you have someone who has a positive full push-up test, and you have a negative, the flexion resistance test. So I do not use the wall push-up test anymore. The only reason I did it because we're in the process of publishing paper to try to stop it. So now we have 49 patients where they had abnormal activation, pectoralis minor hyperactivity, abnormal trapezius activation. They behave like a serratus dysfunction. The wall push-up test, positive. All of them, the flexion resistance tests at the 100 is negative. All of them had exploration of the serratus, which looked normal. So this is just a proof that you have to be very careful when examining this patient before saying that the serratus is not working very well. This is another one I think we presented last time, but this is an excellent example. You can see at rest, there's a slight anterior tilt. When you ask the patient to flex the shoulder on the left side, okay, she's okay. Now, on the right side, the minute she starts to flex, you can see this. So this is very important, by the way, because normally, if the serratus works, we don't start the flexion by anterior tilt of the scapula. It cannot work. It's like someone walking and blocking themselves at the same time. So for her, like the minute she flexes her shoulder, the scapula going in anterior tilt. She had the 3 AMGs. One of them showed possible long thoracic nerve palsy, and the 2 of them were negative. And mentally, she was so determined that this is serratus, and she came to me for tendon transfer. So, but on exam immediately, the minute I saw it this way, because usually in the serratus, what happened, the whole medial aspect of the scapula wings off the chest, all of it, not only the tip. So the minute I saw this way, I knew it was pectoralis minor hyperactivity. And we're gonna see right now why. Because we're gonna do the flexion against resistance. You can see 30, still positive. Now we're gonna go higher. See, this is positive. Now, this push is negative. Serratus is normal. And the patient still is not very convinced. So this is what I usually do whenever they're not convinced. I try to mimic the same exact deformity. The only way I mimic it, I ask them to put their hand behind their back, twing the scapula of the chest, then you put your hand deep to the scapula to tilt it anterior. You don't touch the glenohumeral joint. This way they know you're not blocking them. And you tell them, okay, flex your shoulder now. She said, I cannot beyond 100. And I told her, this is what's happening on the right side. This is a way you can explain it to the patient if they're not sure what's going on. So and these days I'm using more and more the terminology functional and structural. Functional problem in our world, in orthopedic shoulder, except for the therapists are much better, it's very, very hard to talk to the patient and family about. Patients are used to see a positive, something positive, MRI with a positive tear, fracture, injury, positive EMG. If everything is negative and you're telling them this is functional, first they're gonna say, so you think I'm crazy? This is the first thing they think. Well, there's part of it, maybe, I don't know. But it is hard to explain it. So we're trying to figure out ways to explain it on the normal shoulder. So the two ways I do it is the way I showed you, to block the shoulder, number one. And number two, I tell the patient, like, just for you to understand, is like, if I ask you to move your normal shoulder, go ahead, move it. They move it up and down. It takes them like 1 second, 2 seconds. I told her in 2 seconds, you order your brain to move your shoulder. In your mind, you just did this. But realistically, you have at least 6 to 8 muscles working in synchrony to get this motion. If these muscles go asynchrony, you block yourself. You start to understand it more and more. And now we have more and more and more about, with these patients. This is another patient. He's more fluffy, but you can still examine him. You can see when you go up, you can see again, big time, the scapula wing of the chest, especially with extension. He's talking about his complaint. And now I try to do the flexion resistance test. You can see it. Still big time at 30 and 60. I went to 90 and 100, pop is negative. Serratus is normal. And in this patient, we were able to prove intra-op, when we open over the serratus, that it was normal. So this is something I would advise you to use if you have any patient with a question mark serratus abnormal. Now, I will show you then say, okay, show us a case where you have a truly serratus abnormal. This is a patient I operated on. You can see 30, 60, 90. Look, the whole medial scapula wing of the chest. See? At any angle. I cannot. He cannot because there's nothing to pull the scapula on the chest anymore. There's no muscle to hold it and stabilize it. And this is another test I used to do. I don't use it as much. Protraction against resistance, because the main muscle that protracts is the serratus. And if you block it and the scapula wing of the chest, you know the serratus is abnormal. So now I showed you 2, 3 examples of patients who look like have serratus abnormal, but in reality they don't. And one patient who truly have a serratus weakness or paralysis, and you can see the test how it was positive at 30, 60, and 90. So this is just something we have been using more and more, and we talked last time about the pec-pec-C that you heard about, where we release the pectoralis minor and sometimes type the scapula to the chest to readjust, almost like shocking the whole system to go back to the normal mechanics. Now, the muscle paralysis that we always have been taught that if you have scapula winging, this is the reason. It's only and only one reason of the scapula winging, only one reason. And this is why I put it here among other reasons. It's only one. But in our teaching, this is it. This is the main reason. So this patient, for example, he has trapezius paralysis. You can see the drooping of his shoulder. And now we go to the abnormality of remember the shoulder is the glenohumeral AC joint, SC joint. So if you have an abnormality of any of these, is gonna cause quote unquote winking. This patient, I knew her very well. There's one surgeon was suggesting to do scapulothoracic fusion on her, which is a big, big mistake. She's an obstetric brachial plexus injury. I don't know if some of you worked with obstetric brachial plexus. These patients at birth, they have like the pulled arm, they develop Erb's palsy. When they recover, the shoulder dislocate. Essentially, they're dislocated fully. And when the shoulder dislocate, become almost like shoulder fusion because it's stuck. When it's stuck and they try to move their arm, the scapula move as one unit, it looks like it's swinging big time. And it's like in her case, because she cannot move too much because the shoulder is dislocated. And I'm gonna show you her CT scan. This is a CT scan printing. And you can see here, see the shoulder? This is her at rest. This is her in the CT scan sitting this way. And look how it looks on the right side compared to the left side. Left side, this is how it's supposed to be. The scapula sitting nicely on the chest, nice alignment, the humerus on the humeral head on the glenoid. On the opposite side, the shoulder looks like dislocated back. The scapula is smaller. it's all tilted down and her shoulder is out because she's an abduction contracture. So this kind of patient, when they wink because the head of the humerus and the glenoid are stuck in certain position. Then when they move, they don't have the flexibility of the humerus moving on the glenoid. So the scapula move with it as one unit, and they look like they are winging. So this is one of those examples that we spoke about, like if you have structurally a problem around the shoulder area, it can cause the scapula to be abnormal. And if you have bony abnormality, of course, and bony abnormality, if you have patient who have either this part of the scapula is absent or part of the rib is absent, it can cause abnormality in the scapulothoracic articulation. Now, last time, I'm not sure we spoke, I forgot already what we spoke about exactly, but so for if we have a truly paralysis of either the trapezius or the serratus, for the serratus, we do pectoralis major transfer. And essentially, we're trying to transfer the pectoralis from the front to the back to stabilize the scapula the way the serratus does. And the technique, we modified it. We take it with piece of bone, and we transfer the pectoralis from anterior to posterior. And then we hook the pectoralis major to the scapula to stabilize it. For the trapezius, because it is a posterior structure, we do the triple tendon transfer, where we transfer the levator scapulae, rhomboid minor, rhomboid major, and we transfer them from their location to the spine of the scapula to mimic trapezius, to reconstruct the trapezius. And this is here, you can see the dorsoscapular nerve, levator scapulae, rhomboid minor, and then this is after the transfer. These muscles were here, we transfer them laterally, levator scapulae, rhomboid minor, and rhomboid major. They look like a trapezius. And when you do them for the right indication, the patient do excellent. Like for pectoralis major transfer, you can do them through this 2 small incision, and the patient can do really, really excellent. I've done a lot of these, but now I don't see them as much because I'm realizing more and more that most of the serratus abnormalities are functional, not truly paralytic. And the trapezius, the same. We see less trapezius paralysis than serratus paralysis, and again, they have very good outcome after the triple tendon transfer because of the restoration of the mechanics. This kid, he has an absent trapezius, in fact, and he did not have any shoulder abduction or flexion. This is him a year after surgery, after triple tendon transfer. Again, we're trying to restore the mechanic by substituting the absent muscle with the muscle transfer. Yes?
I have a question about the Erb's palsy. So what do you do for a surgical intervention for that?
The glenohumeral joint. So they are dislocated. They have no shoulder external rotation.
Okay.
So if the shoulder is dislocated, you try to reduce it. There's a bone deficiency of the glenoid. You try to graft it. They have no external rotation at the lower trapezius. It is really very complex reconstruction, but it is an idea that the scapula can wing if... Have you seen the cases of shoulder fusion? Any of you? No. So when we fuse a shoulder, you know, like how we can get a shoulder fusion to work. If you keep the patient arm on the side and fuse the shoulder, they cannot move because this is it.
Yeah.
So during surgery, we try to position it. Let's say you move the humerus up and put it slightly internal rotation. You bend the elbow to make sure it reaches the face, and you fuse it in this exact position. Now at rest, the scapula start to move slightly more medial so that the patient be able to put the arm on the side. But if they want to move the scapula, because they're only one bone block, so they move the scapula as one unit, they get up and they get it this way. But if they get their arm down and they force it down, the whole scapula wing of the chest because it's one unit. The main reason the scapula does not wing of the chest when you move because the humeral head is gliding on the glenoid without any pressure, so they're independent. And this is what happened in this patient. It's a complex case. In fact, this case, I presented it in the academy, and I had J.P. Warner, Ben Kibler, Jay Keener and I tried to ask them, and it tricked them even. Like, it is tricky, but just to understand the concept that not every time we see something winging off the chest, it means we have to look for the cause. So this one, they usually dislocate. You have to reduce them. You have to do tendon transfer and reconstruct the glenoid. So, no problem. Any other question? Okay, so the idea of the scapular stabilization or reconstruction, we start to add a little bit more layers to see if we can do things less aggressive. They cannot necessarily of the optimal functional, but will be like close. And we came up with a number of surgeries. The pec minor release and scapulopexy I showed you, for those of you who were here. So what we do, we expose the distal tip of the scapula. These are the patients I told you they have a positive ball push-up test and negative flexion resistance test. For these patients, what we do, we expose, we confirm the serratus is normal, we release the pectoralis minor, and we do a scapulopexy where we put tendon allograft between the rib number 7 and the distal tip of the scapula. What does this do? This is mainly to hold the scapula on the chest for a period of time so that the patient, when they start to move their arm, they start to activate them in a sequence normally. So this is the purpose of it. The other type of surgery we came up with is scapular tethering. A lot of patients, they have the scapula droop down. The muscle is weak but not fully paralyzed. So in this case, what we do, we use an Achilles tendon allograft, and we pull the medial scapula and attach it to the spine just to pull the scapula backward. It will act as an internal splint instead of doing muscle transfer. And the third one is if you have, like, let's say FSHD in someone very young, because both scapulas are down, we do right to left scapula tethering. Where we do Achilles tendon allograft, we attach the medial scapula on the right to the left. Again and again, for those like of you have used the figure of 8 strap, it is similar, but you know this one, they can cause a lot of irritation of the skin. This works like an internal splint. So one procedure, pectoralis minor release and scapulopexy. The other one is tethering the scapula to the spine. The third one, right to left scapula. These are only static type of reconstruction just to help restore the scapular mechanics. This patient is the pec minor hyperactivity, posterior subluxation of the shoulder, and you can see the very abnormality with the stem. We did for her simple arthroscopic pectoralis minor release scapulopexy, and this is her 6 weeks after surgery. Within 8 weeks, she went back to taekwondo, and she's doing great. Now, in the past, I used to do pec minor major transfer on these. Do they work? Yes, because they're doing the same job. They're pulling the scapula, but do they need it? No, they don't need it. So now they lost their pec major muscle, and they don't need it. But this is what I thought the right thing for the patient, and I think I was wrong. This is a patient with FSHD. He's a medical student. He did not want to have a scapulothoracic fusion. And you can see the tethering, by the way. You can see the Achilles tendon allograft tethering from right to the left. And he's very happy because he had to miss 1 year because he could not write, he cannot type, he cannot do much, and now he's back to medical school, and he's pretty pleased about the outcome. This is important for those who don't want scapulothoracic fusion in FSHD. You know FSHD, all of you, or no? Have you heard of facioscapulohumeral dystrophy? So FSHD, sorry, I should have mentioned this. So FSHD are patients with muscular dystrophy. They have essentially almost complete atrophy of the trapezius and the serratus, and it is genetic. So you have like big time winging of the scapula, and they're very, very dysfunctional. And the best treatment for them is fusion of the scapula on the chest. Some of them, they don't like it. We'll do this procedure. We came up with this procedure for them. And others, they are pediatric, where the scapula is still cartilage. You don't want to fuse it. So we do it on them. Like this kid, he had also FSHD, and we did the scapula right to left scapula tethering. He was very, very limited in function, and he regained function, which is, at least for this time, even if it could be temporary or not, I don't know. I haven't revised except one of these. So this will be a solution, almost like an internal splint, to help stabilize the scapula to improve the shoulder function. This patient, in fact, he does not mind this, but he's an OBGYN. He really liked to golf. He had lung problem that you cannot do scapulothoracic fusion on. We did on him right to left scapular tethering, and he was able to get back to his golfing. This is all what he wanted to do on retirement. So this is the idea of trying to stabilize the scapula with different technique. And again, probably if we do more lectures, we'll dig into this, because this essentially, we're trying to get into everything about the scapular abnormality and treatment. We'll go now to the next level. And if you have a structural problem, these are the patients, like for example, with tumor or cancer, that you have to resect a big portion of the scapula. Now you have a structural problem, and you don't have bone, you don't have muscle. Like this patient, you have to resect big part of the scapula, for example. Sometimes you have to resect portion of the glenohumeral joint. So these are become more challenging. So this one I like to present her often because I don't want something like this to be missed. This is a 14-year-old 5 months we went to PCP because she has scapula winging. They said, you know, if you go to a physician, you say scapula winging, they say for a year you have to watch. So you say like, they did not examine very well because at rest the scapula was off. When she flexed, the scapula is normal. This is a big, big red flag that could be a tumor. Because if there's something pushing the scapula off the chest, at rest it looks proud. When you flex, this tumor goes on the side of the chest here, it will hide. Then your scapula looks normal. So this is completely the reverse of anything abnormal about the muscles. Because at rest, it looks proud. When they flex, it looks normal. They waited for a year, and then eventually someone ordered imaging, and she had chondrosarcoma of the scapula that they sat on it for a year, which is because of a wrong exam. Very uncommon, but it should not be missed. So it was really very big, big tumor. And this is why it looks like big time scapula winging. So it requires big resection. So most of the scapula is resected. Now what can we do to stabilize the scapula? So you have to take the tumor out to save the life of the patient. And you can see this is a huge cancer. And now we have very little bone remaining. So we need to stabilize the scapula on the chest. The best is to fuse it, but because it is very thin, the portion remaining, we have to do some modification to make it very stable. So these are her ribs. We took the rib number 2 and number 3 to use it as a post to stabilize the top part of the scapula. And then we use an allograft to support the rest of the scapula here, fibula allograft. And the patient had only and only one muscle because her rotator cuff, remember, if you take the scapula out, there's no rotator cuff anymore because you took the subscap, everything. The only muscle remaining is teres major here. So this is her reconstruction. And then we took the teres major and we transferred it to the posterior superior rotator cuff. So this is eventually what it is. It's a stable scapula with a muscle transfer. And she came early on. She started to have very good function. And this is her 1.5 years after surgery, playing volleyball. In fact, she won the best defense in her volleyball team. So it's not normal scapula, but it's a stable scapula on the chest in certain position that she was able to adapt, and she had no rotator cuff. With one tendon transfer, she was able to regain function. Very quick, again, another one, 31, she's a nurse. She had pain, some winging. Also, it was delayed, this one was treated for winging as well, but she ended up having a big sarcoma of the scapula that requires resection. In her case, because the spine of the scapula was preserved, we did like the 3D printing and we were able to reconstruct with the ilium. So this is reconstruction of the scapula with an ilium. And we attached, in her case, we did not do fusion, we attached the muscles, all the muscles on the scapula. But look at her, the cancer, it's a very big one. And this is the ilium healed after healing. And this is her, I think it was 1 year after surgery. She went back to her kayaking and she has very decent function. We did for her lower trapeze transfer for shoulder external rotation because again, she has no rotator cuff. And she regained very decent function. So I think this is a lot of material. Probably I'm gonna stop right now to see if you have any questions. Okay, thank you.